because we can have this syndrome. Okay? And in the other way, the eclampsia is the stage after the preeclampsia. Okay? If we don't treat good a preeclampsia, it can finish in an eclampsia. That is generalized tonic-clonic compulsions and coma. Okay? The 50% occurs before the labor, 30% during the labor, 20% after the labor. What is important here, like the immediate treatment, is to ask for help, because this is an important emergency. Okay? To prevent, while the patient is convulsing, you need to prevent for her to hit in the head, so you put something near the head, like a cloth or a mattress or whatever, and you wait. There is nothing that you can do in that moment, okay? Because the patient is moving a lot. But you wait, and after that, or during that, when the patient is more in a tonic stage, you put the patient in this position, okay? Because they can swallow the tongue, so the first part of the ABC is to have open airway. In this position, you can open the airway, okay? And you check all the vital, of course, the saturation, you can put her on oxygen. And then we start the prophylaxis for a new eclampsia, and we're talking about after in the treatment. So in summary, why is it important to know all of this classification? Because the definitive management of the preeclampsia is to finish the pregnancy, okay? In this situation, are the situation that we talked in the last part, okay? The HELP, the eclampsia. So we have to have in mind always this thing, okay? So we start, if we are in front of a patient without severe fevers, the risk of the mother is not too much, but the risk of the fetus is a lot for the prematurity, yes? So in that situation, we finish the pregnancy in 37 weeks. We have time. Yes, because the mother hasn't severe fevers. But of course, when the mother is preeclamptic, without severe fevers, she can develop severe fevers. So it's very important the monitorization, the continuous monitorization, because she maybe can develop a severe fever. By the other hand, we have all the emergency situations, the HELP, the eclampsia, and all the, for example, the uncontrolled BPs are emergency fevers. In this situation, the risk of the mother is too much. The short-term and long-term life risk is very high. The mother can die at any moment. She can have a DIC, she can have a big hemorrhage, she can have a hemolysis, she can have anything that can kill her. So the risk is very high, so we are not taking care about the baby, we have to take care about the mother. So always interruption of the pregnancy, okay? And when we have a preeclampsia with severe fevers, now we're in the middle. So the risk of the mother is not too much, but it's quite a big risk. We need to take the decision based on the gestational age. So when the gestational age is under 34, the risk of the preterm for the baby is less than the risk of the mother. So we do conservative management. Okay? And also we give steroids, because this can turn to this in any moment. So we need to be prepared to finish the pregnancy. So we give steroids now, because maybe we will need to finish the pregnancy. And you know that steroids are for the preterm babies. Okay? We will have a class about that the next week. And when it's above 34 weeks, we finish the pregnancy. Okay? And we don't wait for the steroids to act. We interrupt despite the steroids. Okay, so now we have seen the longest part of the class, that is the physiopathology and how to diagnose and classify the pregnancy. Okay? Now we're going to talk only about one slide about the prevention of the preeclampsia. This is very important for the ones that are going to work in the antenatal care, okay? Because this treatment is responsibility of the healthcare provider in the peripheral area, in the rural area, in the little health facilities. And why is so important? Because with this treatment, we can prevent the preeclampsia to appear, because we give this treatment during the bad placentation process, and it's the process when all the preeclampsia start. Okay? So, Abdi, can you read this risk factor, please?
Personal history of preeclampsia.
Okay.
Actual pregnancy, previous chronic hypertension, diabetes mellitus stage 1 or 2,
okay.
Kidney disease, autoimmune disease, SLE, and APS.
You know what is this?
Yeah. Systematic lupus.
Very good. And this?
erythematosus. Yeah.
Antiphospholipid syndrome.
Antiphospholipid.
Have you read about it? Well, there are much more. It can be rheumatoid arthritis. Okay. Any autoimmune disease. So all of these are high risk factors. Okay. If you are doing an antenatal care and you have a mother that have only one of these, you can start giving the prophylaxis. Okay. If you have a mother that doesn't have any one of these but have two of these, you can start giving the prophylaxis. And with this, the studies that have shown that this doesn't make the risk of preeclampsia going low, but this makes the risk of severe fetus going low. So maybe with this, we will not prevent the appearing of preeclampsia, but we will prevent the appearing of the severe fetus. So we prevent the mortality, we prevent the eclampsia, we prevent all that things. Okay? So it's very important to know this, because for example, let's put an example of a mother that is African. Okay? Because here we're in Africa, so all of us, all of you, have more risk to develop preeclampsia. And, for example, she is his first pregnancy. Nulliparity, African race. She had the criteria. And here we have seen a lot of primigravida, and any one of the primigravida that I have seen doesn't have, any one of them have this treatment. So I encourage you, please, to remember this. Because with this we can prevent a lot of pathologies for the fetus and for the mother. We can save lives. Okay? And it's only to give a low dose aspirin every day since you detect the risk factor until the week number 36. Okay? That is the only treatment that you have to give. And when you give before the week 16, it's a better treatment than when you give after, because here you work in the process of the placentation that I told to you. Okay? So you have this in the papers that I give. So here is the thing that I only to explain that the part of the placentation. Okay? So now we're going to see how we approach this patient. Okay? So Regina, what do you think? What do you think you have to ask to a patient that you are suspecting she have preeclampsia? Very good. Yeah. To ask if she had previous diagnosis of the disease hypertension. Very good. Like more in the present complaint, in the past week. Which symptoms you have to ask? Dizziness. Very good. Blurred vision. Very fine. Epigastric pain and headache. Okay. If someone know another, can say. It's okay. I don't want to make a very long class, so we're going to continue. But if anyone wants to add something, you can add. Okay. So, as I told you in other seminars that I think any one of you were present, Benedict, you were present in the seminar number 7? I think you were present.
Yeah.
We talk about this, the systematical approach pyramid. So, a patient is like a book, okay? I always say that. So, when we want to know something for the patient is not coming to the ward like with a letter here, no, I have preeclampsia. The patient doesn't know that she has preeclampsia. She only comes with a complaint. Maybe she comes because she has dizziness. So you have to ask the patient, una sikia kizungu, una sikia mtoto anacheza. All the things that I learned in Swahili, you have to ask. That part of asking and listening the patient is the clinical history, okay? And this must be the first part. So this is the first chapter of the book. After that, when we finish the complete clinical history, about the previous disease, about if she had a previous scan, if she had the antenatal care, all of that. When we finish that, we have a kind of information, but we need more information. So we start with the physical examination, that is the second chapter. If we do the physical examination before and the clinical history after, maybe we wouldn't know what to do in the physical examination because we focus our exam because of the complaint of the patient. So it's very important to have the order, okay? And there are some women that are very normal, controlled pregnancy, any complaint, anything, she's only in active phase of labor, but she's okay. With this and this, we have the diagnosis and the mother comes to the ward and everything is normal. But there are some situations that we need other further tests. lab test or ultrasound and all of that. Okay? So now we're going to talk about how to approach the patient. Because maybe we can be expert about preeclampsia with all of the things that we have talked about the class, but we need to be expert about how to discover the preeclampsia in that specific person. That is why we're talking about the approach. Okay? So in the clinical history, we have to ask about the risk factor of the mother, to ask about if she had a previous preeclampsia in the previous pregnancy. That is a very important risk factor. To ask if she had twins, because the twins have a bigger placenta, so that is also a risk factor. Chronic hypertension previous is a very important risk factor because these have the complication of a severe preeclampsia superimposed. Yeah? So this leads to have more risk for preeclampsia. Diabetes, all of these things that we talk about in the slide of the prevention with aspirin, we have to ask. Also, ask about the severity symptoms. So the visual disturbances, epigastric pain, if she had seizures, okay? All of that. And the antenatal care visit. You can see in the chart if she had high BPs since the start of the pregnancy, that means chronic hypertension, or if she had high BPs only after the week number 20. Okay? And also to have all the things about the gestational age, because we need to take the decision about the interruption of the pregnancy, we need to have the gestational age. This, I'm not going to read, but it's in the Kenyan guidelines, so it's important to read. You will have in the presentation. After that, we have the physical exam. So, again, we need to be ordered, okay? Try to put yourself in the situation that you are in the ward, like as we were today in the morning, a few minutes ago. Always you start with the general exam. You have to make the ABC, of course, very basic, and the neurological status. So if the patient is awake, if the patient is responsive, is not confused. Emphasis on the BP. Okay, take the BP, and if you take the BP and it's high, remember that after all the exam, take it again. Maybe it can be high again. Okay, and check in the general exam about pallor, that it can happen in the HELP syndrome because of the anemia, because of the hemolysis. Edema, that is very normal in preeclampsia. Jaundice, also in the HELP syndrome because the bilirubin increases. And respiratory pattern because she can have a pulmonary edema. All of that is in order to rule out the severe features, okay? So by segment, you have the cervicothoracic segment. You check the jugular, maybe she can have a heart failure, heart, lung, and auscultation to listen how it's working the heart and the lungs, if she have water in the lungs. So you have a stethoscope or not? All of you? Okay, so don't forget, if you have a Atlantic patient, you need to do this part of the exam, okay? Well, the epigastric tenderness, to check the Leopold, all of the things that you do to a normal mother to assess the position and everything, because maybe if you need to induce, you need to know the contraindications for induction that can be a podalic presentation, and you only can rule out that with the Leopold, okay? Uterine dynamic, to check if she's in labor or not, okay? This is a very special part, that is the musculoskeletal part that we don't do usually in all the patients. But if we have a patient with high BP, we need to assess the tendon reflex. Okay? The easiest is this one. And what happens? When we have an alteration of the reflex, we have two things. One is that it's hyperexcitation of the reflex, that you do a little stimulus and it's like playing football. Yeah? That is one thing. And the other thing is that increase the area that you can trigger the reflex. So maybe you can do like this, and she will do like that. Or you can hit very down, or in the side. So when you increase the area and you have the reflex, it means there is a hyper-excitability there is affection of the neurological system. Okay? That is a severe fit, or edema, because you also check the fit, so you can check the edema. And genital, you do PE or speculoscopy depending on the situation, okay? And after that, you will have further tests. So, who is more sleepy? Okay, Regina. Which are the minimal laboratory studies that you think you have to ask in a patient with preeclampsia? Okay, LFTs to see what? What means LFT? liver function test. Okay? So to rule out the criteria of severity, that is when you go up with the LFTs. Yes? Okay? And the USCs, I don't know what it means, sorry, because I forget it. Urea, electrolytes, and creatinine.
Yes.
So to rule out the impairment of the renal function. Yes? Okay. Very good. So you say those two. Do you think there's something more that you can ask? Full hemogram. Okay. What the full hemogram have a lot of different things. Which are the things that you need to look precisely?
Platelets.
The platelets. Okay. The
WBC. Leukocyte.
the leukocytes. Okay. For what?
HELP syndrome.
HELP syndrome. Okay. John, you say no. Why do you think the leukocyte doesn't have to be with the HELP syndrome?
Because I'm looking at the definition of the HELP syndrome. It's hemolysis related liver enzymes and
Yeah. Yeah.
So it has not just less to do with the lymphocytes and has more to do with the red blood cells and the
Yes. Yeah.
So for the leukocytes we test because if we have to give therapy for like lung injury, we check for like if there is any infection or something, just in case.
Okay. So the leukocytes, most of the situation we use it to search infections because it's like it's a sign, a lab sign of systemic infection. Yes, but it also increases in a normal labor. So it's not so specific. The more specific is the clinic when you look the tenderness, all of that. But here the leukocytes for the HELP syndrome or for severity features in preeclampsia are not useful. Okay, it's only useful for rule out infection and all of that things. But here the homogram we have to look at the platelets and the red cells because it can happen different things in preeclampsia. We can have hemoconcentration in the first part, and if we have a HELP syndrome, we will have anemia because of the hemolysis. Okay, and also if we see a photis in a microscope, we can see broken red blood cells. Okay, well, I think we're okay with that, but also we need things to assess the fetal well-being. So there is also an important thing, that is the ultrasound that you didn't say. Okay? So the field hemogram to see the platelets, the HB, the red cells, the USCs, the creatinine, yes, the blood uric nitrogen, the LFTs, the LDH, that is, in this hospital we don't have it, but it's an enzyme that is inside the cells. So if the LDH is over 200, it means that the cells are broken and the enzyme is going out the cells. Okay? Urinalysis, we didn't say. I also didn't say, so I have the mistake. You see? Very good, John. One clap for John. To assess the proteinuria. Very good. And the ultrasound that I said to you because to estimate the fetal weight, to see the amniotic fluid. Okay? If there is no amniotic fluid, it's also a sign of placental insufficiency. And to assess the gestational age, that is very important because here we know that all the mothers that come here to the web doesn't have previous ultrasound, and it's important to know the gestational age when they don't know the LMP. And group and cross match, only to have it because maybe this mother can be a serious mother, can need transfusion or can go to cesarean section, so we need that thing. Okay? So now we have seen the pathology, how to diagnose and classify, the prevention, and how we have to approach this patient. So now that we approach the patient and we have all the knowledge and the information, we need to put in practice. So what do we have to do to treat these patients? We're going to talk about the pillars of the management. Okay? So can someone here say one pillar of management? No? Control BPs, that is one pillar. We have 5, so you said one.
Prevent seizures.
What?
Prevent
seizures or prevent the preeclampsia. Very good. Benedict, you know something? You don't know? Don't worry.
I'm still loading.
Yeah. Monitor well-being. Okay. Fetal well-being and maternal well-being.
liver.
And plan for delivery. Very good, Abdi. One clap for Abdi. Yes. So the 5 pillars are these ones. Okay. Control the BP is the first one that we have to do. Okay. Then to give magnesium sulfate to the seizure prevention if it's indicated, and this too that is monitorized. Because if the mother without severe features but we don't monitorize, she can develop severe features and we wouldn't know. So it's important to monitorize. And the last one that is the most important because it's the definitive management, and we always have to think about this, is the plan to deliver. Okay? From the 1 to the 4, all the interns and all the students and also me, we do it like as robots because it's to do the same. We do always the same. We take the blood sample, the same blood sample, we do the same physical examination, we give the same drug to control the BP. So this is always the same. But when we reach this part of the treatment, it's different from mother to mother because they have different severities and different gestational age. So this part we always forget. So when we are working in a call, for example, and we can we admit the mother, we crack the mother, we do everything, and the other day in the morning in the wardrobe, the consultant come and we say to the consultant, oh, this mother come because of this, she had the diagnosis of this, we did this, so she has severe features and the Sister Tati said to you, so how many centimeters is she? Is she dilated? How we are going to deliver this mother? And you forget to deliver or forget to assess the cervical condition to make an induction. All of that things are because we sometimes forget this fifth pillar. Okay? So I encourage you to don't act like robots and act like thinking in the 5th pillar. Never forget it. Joel, which antihypertensive is forbidden in pregnancy? This is difficult. It's difficult, or not? Sorry for the difficult question, but I want you to be the best of the world. Or better. Better ask like that. Which of these you think it's you can use in pregnancy? Have you listened that it's safe in pregnancy? John?
You can use
Nifedipine you can use, yes. We listen today, we listen to tocolysis, but it's also an antihypertensive. Regina, one of these? Have you listened about Aldomate? Yes? And you know what is Aldomate? The famous Aldomate is methyldopa, that is also allowed. Okay? But hydralazine, it's also allowed. Okay? And we have IV and oral. It's a very effective drug, but it's not so safe. We're going to talk about that. And enalapril and losartan, atenolol. There are a lot of different drugs that are not available for this. And what is the problem? When we have mothers that have previous chronic hypertension, they are on these drugs because these drugs are for that physiopathology, okay? That have another substrate. But the physiopathology that I told you about the placenta and all of that, it's another physiopathology. And it's because of the placenta. The only treatment is the placenta. There's no drug that treats that, okay? And also, enalapril, well, in this slide is the enalapril, that is this, have risk of fetal damage, growth, retardation, okay? The diuretics are also forbidden, the furosemide, the hydrochlorothiazide. There are a lot of different drugs that are forbidden. So if the patient is in that antenatal care and you're doing the first antenatal care and she said to you, oh no, I have chronic hypertension, you need to ask her which drug you use for that. And you need to check if that drug is allowed or not, okay? And also refer the patient. So the first pillar is the BP control, okay? Are we okay? Anyone is tired?
No.
Okay.
I am not tired.
You're not tired. Okay. So the BP control is very important to start in the moment that you finish the diagnosis of preeclampsia, you start very fast, okay? Because the BP is related to the organ damage. So it's very important to treat it. So what we use to treat it, we use the Aldomate 250 TDS. We start with this dose and then we can go up titrating, measuring the blood pressure. But we need to reach the target with the diastolic pressure below 100. Okay, that is our objective. So I forget to tell something important. That the BP control have two different parts. The BP control when you have a crisis, and when you have over 160 when 110, that is with IV drugs or oral drugs, but it's very like important monitorization. And the BP control that is when you have above 140 with 90, but below 160 with 110. Okay. So in this, when we have a high BP but not an emergency. So we give methyldopa or nifedipine. Okay, we can put these two together. So this is the maximum doses, and also hydralazine per oral is also a useful drug. But if we have a mother that have, for example, blood pressure of 145 with 92, you don't have to treat it because it's below 100. Okay, the treatment for this is when it's above 100, the diastolic pressure. Okay. This is the nifedipine. I take a photo only for you to know that the formulation in our hospital is 20 milligrams. Okay? Now, when we have the situation of a mother with the pressure above 160 with 110, this is a mistake, it's 110, we have to give IV hypertensive. Okay? Because this is a hypertensive crisis. So this is in that moment, this is being damaged to the brain, to all the organs, and it can develop eclampsia or anything. So we need to treat. And how do we treat? The best drug to use is labetalol, the best. The most effective, the most safe, but it's very expensive. And here we don't have it. So you don't have to learn this part, okay? But we have nifedipine, that is a drug that we most use, that you give 20 milligrams per oral, and after 30 minutes, you take again the BP, and if it's on target, you don't give. If it's not on target, you give again. Okay? You can give after 30 minutes again and again. The maximum daily dose is 180 when we talk about crisis. When we talk about the other, it's less. Okay? And hydralazine, it's an IV drug. Sometimes the patient can have, for example, eclampsia. They are not swallow. They cannot swallow because they are sleeping, and you need to control the BP. You have to give IV, and it's hydralazine. The big problem with the hydralazine is when you give, the BP can go very low. Okay, it's so much effective that the adverse reaction is hypotension. So you have to be aware. Okay, and how do you give it? You give 5 milligrams slow infusion during 15 minutes. You finish the infusion and wait 15 minutes more, and then you repeat the measurement of the BP. If the BP is on target, it's okay. If it's not on target, you give again, and you can repeat that 4 times. Okay. All of that, you do it thinking and what you do. You have to deliver the patient, what do you have to do? It's not only to treat the BP here. We have 5 pillars, okay? Well, the adverse reaction here is low BP, and the nifedipine can give hot flashes and also headache, very strong headache. So it's very important to warn the patient before, so if she have it, she don't be scared. The second pillar that is very important is the magnesium sulfate treatment. Okay? To start this slide, I want to talk to you about the MAGPIE trial. Someone have listened about this? No? It's a study, a very big, huge study about the seizure prevention, where they compare the magnesium sulfate treatment against placebo, that is only to give normal saline. Okay? They compare it, and this study is in a lot of different, it's a multicentric study, so in different countries, different hospitals. It's a very big and famous study. And this study shows not only that this is useful to prevent seizures, this is also useful to prevent placental abruption. It's useful because it diminishes the risk of maternal mortality, and it's also neuroprotector for the preterm babies that are below 32 weeks. So it's a drug that has a lot of benefits and cannot be forgotten. If you have a patient that needs this drug, you have to give it. If you don't give it, the lawyer can give you to jail. Okay. So how do we give this, and when do we give this drug? The magnesium sulfate is for all the patients with preeclampsia with severe fevers. Okay. Never forget, all the patients with preeclampsia with severe fevers. Any severe fever. It can be only headache that is continuous and doesn't respond to paracetamol. You have to give it. Okay, only that, or only a pressure that is a little high, more than the normal. One measurement was about 160. You have to give. Okay. And you have to give it since when you start giving it until 24 hours after the delivery, because all the neurohormones that the placenta liberates can continue. It also can continue until 6 weeks, okay? But continue in higher doses until 24 hours, and you have to give. And when it's forbidden to give? When you have anuria, okay? And some precautions, you have to stop the infusion if you have the respiratory rate under 16 or the urinary output under 30 ml per hour during 4 hours. Why? Because this drug is metabolized by the kidney. If we have a kidney insufficiency, like can be something in the preeclamptic mothers, we can accumulate this drug, accumulate, and it's very toxic. The toxicity level and the non-therapeutic level, like the margin of therapeutic level is very little. So we can go high and have toxicity, or we can go low and have not prophylaxis. So we need to be aware of that. Okay? And we have 2 different regimens to give it. And in this hospital we have both of them. Sometimes we have the intravenous, that is not too common, but we have it. And we have to give one completely in 15-20 minutes. It's one, how do you say? 250 to 200 cc ampoule. Okay? We give in 15-20 minutes, and then we give 1 gram per hour in an infusion. 1 gram, 2 grams per hour. This is not too much available, only sometimes. But the most common is the intramuscular scheme. Okay? And I'm going to detail you a little how to prepare it. If you want to know a little more, we have this. You know where it is? This? Yes? Have you seen it? It's in the ward. Okay? In the obstetric ward. So in the ward you can read it, and also if Dr. Watao is asking to you, you can take a look and be very smart with your answer. So this is I also take a photo of this. This is a magnesium sulfate ampoule, okay? Are very big ampoules of 10 ml. And in this 10 ml, we have 5 grams of magnesium sulfate, okay? If we know this of memory, we can prepare everything. So to prepare the treatment we have 2 parts, the loading dose and the maintaining dose. The loading dose is 2 of these. We give 8 ml from this ampoule, that is 4/5. We divide this in 5, and we put 4 of these in a syringe, okay, with 12 ml of water for injection. And we put this IV slowly in 10-15 minutes. If we give it this fast, the patient will have adverse reactions, okay? Hot flashes, so we have to give this in this velocity. And also with this, in addition, we give